A very good evening, a very warm welcome. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session on Clinical Approach to Parkinson's Disease by Dr. BINDU MENON. I'm thankful to all the participants from all over the country who have taken out their valuable time and are attending this evening talk. Pharm D Community has been created with the charter to provide free webinars by doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the wholehearted support of my core committee members. Thanks to Kuldeep, Pooja and Vaishnavi. I would also like to thank the members of Pharm D Community who have recently joined the community. It's my pleasure to release the flyer of our next webinar. The registration link will be posted in the chat box for both Zoom and YouTube. So there's a webinar on ankylosing spondylitis, which is to be conducted on next Saturday. And there is also one more webinar in the same week, which is on post-traumatic stress disorder by Dr. Harish Shetty, and this will be conducted on Sunday. Timing is 5 p.m. Registration links will be posted in the chat box. We also have an upcoming free webinar series on gastroenterology, which is starting from February 13th. It's a 1-month course, so interested candidates can contact Kuldeep and Vaishnavi, and the registration for the same is uploaded on our YouTube channel too. I would like to hand over the session to Pooja to introduce our speaker for today.
Thank you, Aishwarya. Good evening, everyone. Our speaker for today is Dr. BINDU MENON. She is the Senior Consultant Neurologist at, sorry, just a minute. Sorry for the disturbance. Thank you, Aishwarya. Good evening, everyone. Our speaker for today is Dr. BINDU MENON. She is the Senior Consultant Neurologist at Apollo Hospitals, Andhra Pradesh. She has completed her MD Medicine, DM Neurology, DNB Neurology, and PG DCN Neurology from London, and FRCP from Edinburgh. She has over 17 publications in various international and national journals, presented over 100 papers, and has 14 chapters to her credits. She has a fellowship from 4 national organizations like the Geriatric Society, Indian Academy of Neurology, Indian College of Physicians, and World Stroke Association. She holds various posts like Research Committee member of the World Stroke Organization, Indian Subcontinent, and the Epilepsy representative in the special group on neuroepidemiology of the World Federation of Neurology, Chief Editor Epilepsy India, President Epilepsy Association, NALOR, and Webmaster IEA, GC member, and ECIEA member. She has also been a recipient of 18 international and 24 national awards for epilepsy and stroke care, which includes the prestigious International League Against Epilepsy Leadership Award at Barcelona, 2017 World Stroke Award under Individual Achievement category from the World Stroke Organization at Montreal, the H.C. Bajoria Oration Award from the Indian Epilepsy Association and the Indian Epilepsy Society, Dr. Karimullah Indian Medical Association Oration Gold Medal, among others. She has founded the BINDU MENON Foundation in August 2013. She has been instrumental in starting novel projects for the first time in the country, which includes the Neurology on Wheels mobile application, which is the epilepsy app for epilepsy health, and also tele-awareness programs and stroke rehabilitation app for stroke. She has published several educational material like books, pamphlets, and comics. With this introduction, I would now like to hand over the session to ma'am. Over to you, ma'am.
Ma'am, kindly unmute yourself.
Pooja, thank you very much for your kind introduction, and Aishwarya and the whole team for having me here. And it's very nice to see all the bright faces, the ones which I can see, the ones which are hidden and I can't see. Without much ado, let me start off today. And as Aishwarya has told me, we are going to touch upon only the clinical approach to a Parkinson disease, and we are not going to touch on the management of Parkinson disease because that's a new and lecture in itself. So any questions which you have on the clinical approach, because as goes with any other disease, neurology still remains a clinical approach, and investigations are always secondary. If you see the patient well, take the history well, examine the patient well, and then diagnose the patient well, you can route your investigations and your treatment in the following manner. Allow me to share the screen.
Ma'am, you're the co-host, like you can share.
Yeah. So as I said, we will now start on the Parkinson disease. So first, when we are looking at a patient with a movement disorder, we need to know whether the patient is having what type of movement disorder. So whether the patient has got a low movement or a high movement, that is a hypokinetic or an akinetic rigid syndrome, or a hyperkinetic movement where the patient's movements are more than needed. So from there, we start our examination, and from there, we come to a akinetic rigid syndrome, in which the patient has akinesia and bradykinesia, means there is a paucity of movements for the patient. Paucity of movements either in initiation or in the speed of movement or the amplitude of movement. That is akinetic rigid syndrome, and Parkinson's disease per se comes under the umbrella of an akinetic rigid syndrome. The next part is the next division of movement disorder is a hyperkinetic movement disorder, which we are not going to talk today, but then they can be in two forms. One is a jerky, that is any movement which has got jerks included in the movement disorder. That is myoclonus. You would have seen patients having myoclonus. A common example is a sleep hypnic jerk, that sometimes when people drift into sleep, they get a small jerk that is known as a hypnic jerk, and that is a normal variant, and it's not a pathology, but the same one, if it is more devastating, then it becomes a myoclonic. And the other ones are chorea, that is arrhythmic, apurposeful, semi-purposeful movement, tic, that is again a jerky movement. The non-jerky movements are the dystonia. So we come to the akinetic rigid syndrome, that is a Parkinson's disease. Parkinson's disease is a very common movement disorder which is seen in the neurological practice, and the diagnosis and management is challenging for reasons which I will take you to the further slides. According to the global burden of disease, the Parkinson's disease is going to double from about 7 million in 2015, and where we are going to stand in 2040, it would be around 30 million. So if I may put it, that probably Parkinson's disease would come under the pandemic situation, what we are calling a 13 million people suffering with a chronic neurological disorder. And in that, the idiopathic Parkinson's disease we describe as the most common form of Parkinsonism in clinical practice. Now, let us see the historical milestones. In 1817, can you imagine, way back around 200 years ago, James Parkinson had given a good description, and he had published the paper on essay on the shaking palsy. And from there, the journey started, where just to know what all happened over the period and decades is in 1912, Frederick Levy discovered the dopamine deficiency in animal models. And then we came to know that dopamine is the chemical that makes a person move and gives the speed to a person. In 1957, Arvid and Ole described the link between the dopamine deficiency and Parkinson's disease. So now from the animal model, they came to the humans, and they found that yes, dopamine deficiency is the one which produces Parkinson's disease. And yes, if there is a chemical that is producing a deficiency, obviously we have a manufacturing ability to give that chemical in a tablet form and give a response to the patient. In 1967, the intravenous levodopa in high doses was investigated and was brought out by George Coetzee. Again, afterwards, in 1982, heroin, a synthetic agent, heroin, was found to have a Parkinsonian, that is an extrapyramidal syndrome-like effect on the patients. Why that was important, and that was another landmark, because now we know that MPTP, which is toxic to substantia nigra, dopaminergic neurons, there we found out that when MPTP is given, substantia nigra is the area which produces the dopamine, and that is the area which is affected, and that is known as drug-induced Parkinsonism. So we know that there are certain drugs which can induce Parkinsonism, and we are not supposed to use them in a particular sect of individuals. And in 1996, coming from a degenerative disorder, in 1996, we now know that there is a genetic alpha-synuclein gene which can produce deficiency, which can produce a genetic form of Parkinsonism. That is, it's not only in the elderly, we can see it also in the young. So what is Parkinson's disease? It is a chronic, it is a progressive, it is a neurodegenerative disorder. Why that is important for us to know? Chronic, because once you have diagnosed a patient with a Parkinson's disease, he remains with the disease or diagnosis. That is why it is very important to also know that the patient is not having another form of disease which is mimicking a Parkinson's disease. That's why a clinical acumen should be perfect, and we should have the diagnosis in the first go itself. It is progressive. Over a period of years, the patient is going to have progression in his symptoms, in whatever the symptoms may be, because it is a degenerative disorder. It is due to early prominent death of dopaminergic neurons in the substantia nigra pars compacta. So that's where the crux of the disease is. And there is a widespread presence of alpha-synuclein, which is an intracellular protein, and it comes under the synucleopathies, that is a disorder. The best part of the Parkinson's disease is that there are two parts to it, that is the motor and the non-motor symptoms. Why that is important is that over a period of time, the motor symptoms are amenable to medical therapy, but the non-motor symptoms are difficult to treat with a medical management, and the patient's sufferings are more for the non-motor symptoms as well. Also important, that over a period of years, the patient would be having non-motor manifestations, but which is not brought out, and for which the diagnosis of the patient becomes delayed. It is a disease of the elderly, as I said, and the incidence and prevalence of PD increases with the advancing age. That is, 1% of people over the age of 65 years are bound to have Parkinson's disease. But having said that, it's not only the disease of an elderly. Early onset Parkinson's disease, that is people who are less than 40 years of age, is EOPD, comprise 3 to 5% of all Parkinson, of which less than 21 is juvenile Parkinson and 21 to 40 is young onset Parkinson, and they are the genetic Parkinsons. Now we come to the clinical syndrome core. The criteria according to the United Kingdom Parkinson's Disease Society Brain Bank for probable Parkinson's disease, the main feature for the patient should be bradykinesia. So as I said, when we were describing the movement disorder per se, either it is a akinetic rigid syndrome or it is a hyperkinetic. So the core feature for the patient should be bradykinesia. He should be having slowness of movements with one of the following features. Either it could be rigidity, or it could be a resting tremor for the patient, or there could be a postural instability. So either one of them, along with bradykinesia, would form a clinical diagnosis of a Parkinson's disease. To remember it correctly, a mnemonic trap has been given, TRAP, which is tremor, rigidity, akinesia or bradykinesia, and postural instability. Apart from that, two other caveats needs to be attached, that is a good response to levodopa. If it's a Parkinson's disease, if it's an idiopathic Parkinson's disease, The moment you have diagnosed the patient with a Parkinson's disease and you have initiated the medication for the patient should have a response to levodopa, because we know that it is a neurodegenerative disorder. We know that this disease is caused by a dopamine deficiency. So it has to have an effect on the with the dopamine supplementation. If it is not having a response to a levodopa, then your diagnosis is in doubt and you need to see the Parkinson's disease mimics. You should also be very wary when you are examining the patient. You should be seeing that there are other factors which are not seen in the patient. That is an absence of atypical features, which I will come in the future slides. So as I was mentioning, one is a motor, that is a bradykinesia, that is a trap, that is a tremor, rigidity, akinesia, and postural instability. That is a core feature, and that is what you're seeing the patient with. But the other non-motor symptoms, unless you ask the patient, or most of the times the patient moves around with these symptoms pretty long ahead in the before the patient has been diagnosed, can be put under 4 categories. They are the neuropsychiatric, autonomic, sleep, and sensory dysfunction. Having said that, it does not mean that any of the persons who come to the outpatient for any doctor has any of these features falls under a Parkinson's disease. No, but these are the non-motor manifestation which can precede, plus they can continue with the patient and can be devastatingly more than the motor manifestation. The neuropsychiatric manifestation are depression, anxiety, apathy, hallucinations, and cognitive decline in the form of dementia. Autonomic, which is very prominent, is a constipation and continues to remain during the course of the disease for the patient. Orthostatic hypotension, it becomes a little more prominent later on in the course. Urinary changes the patient can have, and sweating. Sleep, which is very important, is one of them is a RBD, is the REM sleep behavior disorder, in which all of us know that in a sleep cycle, we go through non-REM and REM stages of sleep, in which REM sleep disorder, when a person dreams, in a person with Parkinson, when they have RBD, that is REM sleep behavior disorder, the person starts enacting out the dreams. That is, when he's sleeping, he might start moving his hands and legs, he may kick off his spouse, he can fall off from the bed, and they can look like psychiatric disorders. So they are classical, known as RBD, and it is very essential to ask the history that does the patient have any funny moments in sleep, and does he have bizarre behavior in sleep, so that can be treated appropriately. Can have insomnia, can have sleep fragmentation. The patient can have excessive daytime sleepiness, and that can be very devastating again, because one, the patient is extremely slow, and then the patient has got excessive daytime sleepiness. So you can imagine if the patient wants to carry out his daily activities, then it becomes difficult for him. The patient can have restless leg syndrome as well. The fourth non-motor manifestation is a sensory dysfunction, where the patient has got pains. The pains, as well as the patient has got paresthesias of the limbs, and patient has got olfactory dysfunction. The patient can have loss of smell. And there have been studies which have shown that loss of smell or decreased smell has been seen quite early in the patients with Parkinson's disease. So these are the non-motor manifestations that can precede, would be there during the course of the disease, and can become very prominent and can be a problem for the patient during the course of his illness. And then it is also very difficult to manage, because there are no pharmacotherapeutic management strategies directed to the non-motor manifestations. Why that is important? Then if you could just look at this graph here, this is a Parkinson's disease clinical course, where there is a patient is having a prodromal symptom, and that is a clinical symptom. And that center line where there is a timeline is where we are seeing the tip of the iceberg. So every person has got all these features which are there, which are non-motor manifestation, which are there quite early in time. And these are the subtle motor impairment which the patient would have had while the patient was having non-motor manifestation. And that's why a clinical examination is very essential in these patients. Why does this happen? Why does this prodromal feature is not brought out very early in the course of disease? If you look at this slide, if you would see that unless the patient has got around 50 to 60% of his dopaminergic neurons which are lost, till then the patient does not manifest all the early motor or the early to mid stage motor manifestation, the features of the Parkinson disease, but continues to have some prodromal manifestation. So it is very difficult to catch a patient in a prodromal stage where the patient is having non-motor manifestations. So now let us take one by one each manifestation and clinically dissect them and see how a person will come to you if the patient has got any of these cardinal features. So let us take bradykinesia. So what is meant by bradykinesia? It is a generalized slowness. So in general, when you want to look at Parkinson is, the Parkinson patient is slow. Everything is slow. His thinking is slow, his speech is slow, his face is slow, his walking is slow, his gastrointestinal tract is slow. That's why he's having constipation. Everything is slow. So that slowness produces the frequent habitual automatic movements in a person to be absent. Like when we are talking, I'm moving my hands, I'm adjusting my spectacles, I may adjust my dress, I may take my hand to the hair, I may sweep things on the table. But if you look at a Parkinson patient, he would have the habitual movements would be absent. So this is quite early in the course where the patient becomes like a rock and he just moves if it is absolutely necessary and does not do the habitual movements. That is the time when you are probably supposed to suspect, I won't say diagnose, but where you're supposed to suspect a person with Parkinson's disease. Now, if you would look at the bradykinesia and various body parts, I have just divided into these four: from the face, from the speech, from the upper limb, and the trunk and the lower limbs. If you look at the person with the Parkinson disease, one, there would be a reduced blinking. So when you're looking at him, he would be staring at you. So most of the time, what happens is with the expressionless face and the hypomimia and the mask-like faces, the patient looks depressed. So in most cases, in the very early in the stage, when the patient is still not diagnosed with Parkinson and having early features, the patient is taken to a psychiatrist. You can very well understand because the patient is not blinking, he's just looking at you, he's not smiling, he doesn't have much of emotion. And when you're talking, smiling and making all the rattle across in the speech, he is still passive in his movements. So people think that patient is depressed and he's not communicating and he's brought to the. So reduced blinking, how would you know? A normal person would blink around 10 to 15 times in a minute. A Parkinson patient's level would come down to almost 6 to 7 times in a minute. Because the swallowing also is affected, because everything is slow, as I said, his swallowing is also affected. So he pulls his secretions into his mouth and he's not able to swallow, and then he starts drooling. So that's from the face. Reduced blinking, expressionless face, hypomimia, mask faces, the smile features, nothing is there, and there is a drooling. Then we come to the speech. The patient has got a soft, hypophonic, and a monotonous speech. And now what do I mean by a monotonous and a hypophonic speech is, one, we are looking at a volume of speech. We are looking at the amplitude of speech. We are looking at the annotation in a speech. When I'm talking, I sometimes, as an exclamation, I have waves in my speech, and any individual would have that. But a Parkinsonian speech is, if he speaks at one level, that is, he speaks at 1 decibel, and that too, it is very soft, it is very hypophonic, the voice is not audible to the person, and he is monotonous. So again, you can understand with the face and the speech characters, one would feel that he's depressed. When one is depressed, how would talk? I didn't do my work, I have to do it. So you would look depressed. So the person also looks depressed. And obviously, everybody has got a lot of stresses in their lives. So he's again thought to have a depression, and he is again sent to a psychiatrist. In some cases, patient can have a tachyphemia, that is acceleration of speech segments. That is, if I'm talking like that, he can go off. That is, he accelerates his speech as well. So he's low voice, he's same tone, and sometimes he can speed off in that low voice and a monotonous speech. So that is where we talk of speech. Now coming to the upper limbs. When the person is walking, all of us, when we walk, we have an arm swing. That is how we walk. In patients with Parkinson's disease, the earlier stages, one should not miss out. There would be a decreased arm swing, and that would usually be unilateral, one side, because Parkinson's disease, that is the idiopathic Parkinson's disease, is usually unilateral, and it starts from one side. So when the person is walking, all of you should start noting. We don't note ourselves and our colleagues, but all of us swing our hands, but there is a decreased arm swing. In the upper limbs, the bradykinesia is manifested in the form of micrographia. Most of the times, when it happens that when the patient goes to the bank and he puts his signature in the early stages, there is a micrographia. I will show you in the next slide that the letters start becoming very small in amplitude. So the same way as the speech, as the face, as the arm swing decreases, the letters also become small and the bank registers the check, because this is no longer your handwriting and it is not identifiable from what you had earlier. So micrographia in the upper limbs. The trunk and the lower limbs, I go to the next slide. We start with the patient having difficulty in rising from the chair or turning around in bed. Now, when we rise from the chair, most of us, if you are young, as you go old, you may try to take the help of the arms and then you try to raise. But a patient will, if he wants to rise, he'll keeps juggling in his with his feet, and then he will try to rise and he will find it difficulty. So the excess of time a person takes from raising a chair, that means that the patient has having some extrapyramidal syndrome, having excluded other features, obviously, a spasticity or a cerebral or all this. Even turning in bed is very difficult for the patient. Then comes the posture and the stance. The patient with Parkinson's disease starts having a stoop posture, and especially his upper trunk starts bending forward. So this is the form that he attains. And when he starts walking, he walks with short steps. For any individual, when we walk, we keep 1 foot distance between our, at least less than a foot, let us say, between one to the next stride. So in patients with Parkinson's disease, they just move like this. That's known as shuffling gait. In fact, if you're sitting in a clinic and you have a Parkinson patient walking, you can hear the voice and probably understand that there is a patient with an extrapyramidal syndrome coming, and it could be possibly a Parkinson patient. The shuffling, that chuck, 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 chuck sound can be heard because the person has got so much of bradykinesia that he cannot lift the leg and put the foot on for the next stride. So he shuffles his leg. They are short and shuffling with a stoop posture. Gradually, the patient can have dystonia, that is abnormal posturing of body parts, and freezing, that is sudden brief interruptions in gait cycle. I would come and show some videos as well, and can have severe flexion of the trunk that he can almost be bent like this, that is known as camptochomia. So we have completed the bradykinesia as far as the face, the speech, the upper limbs, the trunk, and the lower limbs. How do you test for a bradykinesia? You test for rapid alternating movements. So in any form you can test, that is a finger tapping. You can ask the person to take the index finger and the thumb finger, and any person is able to do it in a swift and speedy manner, and every testing has to be done for at least 10 times. So what are we trying to notice? That if I'm trying to do it in this way, from the 1st to the 10th, the amplitude and the speed has to be the same. But for a Parkinson patient, he starts with a smaller amplitude, he starts with a lower speed, and his amplitude keeps diminishing. So it goes like this, and it decreases. And that's what is manifested in the micrography as well, as he starts with a large letter and it goes with a small. He can also do, if he has got some arthritis of his fingers, he can also do in this way, or the best way we do it is this way. So this is the one, that is rapid alternating movements, large, big amplitudes with speed. Parkinson patient may go like this and may fade off. Or you can do the pronation and supination with your hands flexed forward. The other way to see is toe tapping. So if I assume that this is a feet, the person keeps the heel onto the feet and does this. So in fact, even with the, if you can hear the sound, even if you are asking the patient to do, you can, it has to be regular. It has to be the same amplitude and the same speed till 10 taps. But for a Parkinson patient, he will go like this and he will fade off. And the same you can do for the heel tapping yakinas. So that is the alternating movements that you do for the patient, and that to bring out the bradykinesia. Now, if you look at this signature here and a letter here, you can see that the person starts with a large amplitude, large size letter, and gradually fades off. And this is a classical example for a micrographia. And if you would look at this amplitude, which has been taken in a graph, this is the alternating movement which a regular person will do. You can see this amplitude and the speed, that in within 1 second, how much he is doing, and within 1 second, how a Parkinson patient is doing. So the speed and the amplitude. Next, we come to the rigidity. So what is rigidity? The rigidity is a hypertonic state which is characterized by constant resistance throughout the range of movement, that is independent of the velocity of movement. So all of us know that increased tone in a body can be either spasticity or it can be rigidity. Now, if a patient comes like this, how do I know that the patient is Parkinson and his patient is not having a cervical myelopathy, and that's why he is spastic all over the body? So in a normal individual, you ask, move the hands, and that is, you have the agonist and the antagonist working in equation, and you can see that there is, the tone is normal. In a lead pipe rigidity, the tone is equal all across the agonist and the antagonist. The persons with Parkinson's disease will have a rigidity which is a lead pipe or a cogwheel rigidity, and I have put the diagram of a cogwheel here. You can see that it goes like chick, 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 like in why that happens in a patient with Parkinson is because the patient has got tremors as well. So if the patient has got tremors and I'm trying to do that, so it will be like a cogwheeling. So you can understand, if you're trying to move the patient's arm and trying to test his tone, it will go like a cogwheel. It will move from one hinge to the other. So he can have a red pipe or a cogwheel. In a patient with an upper motor neuron lesion, that is a spastic lesion, he can have a high to low resistance, but that is usually called as a clasp knife. So you know how a clasp knife works. There is an initial resistance which is very high, and then there is a let go. In the same way, when you're trying to move the patient's arm, there will be an initial resistance and then it will be normal. Again, when you're trying to move, there will be an initial resistance. So that is a spasticity. So rigidity, how does it manifest in a patient with the Parkinson's disease in the clinical scenario? One is the posture. The patient will start having a bent posture and he will remain in that posture. He cannot get back to his normal, and in an extreme stage, this is known as camptocormia, in which the patient has an extreme flexion and bending of the spine. Some of the patients can have a lateral flexion, and that is known as a Pisa syndrome. That is the leaning tower of Pisa. Everybody would be knowing that. The patient walks with turned onto the one side. Or the patient can have a drop head, and it's very difficult because eating and everything swallowing becomes very difficult. That is known as anticholis. That is, the patient has got a neck flex like that. In the lower limbs, the patient can have dystonic posturing. He can have dystonic posturing of the arms. The patient can have dystonic posturing of the foot. And one of the most important signs in patients with Parkinson is known as a striatal toe, in which the toe is constantly in a position of an extensor plantar. But that is not an extensor plantar. Most of the times when the patient comes rigid and patient lies down and somebody puts the the knee hammer and tests the plantar response, and before the patient's plantar response is tested, the patient's toe is like this because the patient has got a dystonia, and that is a striatal toe, and it is not a corticospinal tract involvement. So the next we come to 4 to 6 hertz rest tremor. And what is a tremor? In simple definition, it is a rhythmic oscillation of a body part. I just need to take this call. So it is a rhythmic oscillation of a body part. Now, tremor can be of two types. One is rest and one is action. So rest is when the person is in a voluntary muscle activity. There is nothing. The person is just sitting, let us say. The person has got his legs rested onto the ground. The person has got his hands rested onto the hands, onto his thighs, and that is a rest, or is sleeping. Action, it could be postural when the person is holding something. So let me say that I'm holding this phone like this becomes a postural. It keeps still. Kinetic, when the person is moving, I'm going to touch this, I'm going to take this and move it to my hands, that becomes a kinetic. Intention is when the person is, all through the movement, the person's activity, movement is normal, but as soon as the person reaches the target, then the person starts having tremor. So rest and action. Action is postural, kinetic, and intention. And in Parkinson's disease, it is a classical rest tremor. So the first thing is the patient should be examined while the patient is resting, has come to your clinic, is sitting well and is calm. Then only you will be able to. If the patient starts moving his hand, the simple tremors would not be appreciated and the patient becomes in action and the rest tremor disappears. So usually it is asymmetrical, starts with one side, any side, starts in the upper limb usually. Lower limb starting of rest tremors is very unusual. It's usually a 4 to 6 hertz. Patient can have a postural component after some time, usually starts with rest and then goes on to postural. Tremors are absent in sleep continuously. They're never manifested in sleep, and for that moment, most of the movement disorders are absent in sleep. And if the person's attention, if you ask the patient to concentrate, let us say the patient is asked to count to 10, or the patient is made to walk, when you first saw him, you saw the tremor, but then you're not able to appreciate. So how do you bring out the tremor in the patient? Ask the patient to count, he'll start having the tremor. Ask the patient to walk, he'll start having the tremor. The classical is a pill rolling tremor. You know the pill, the medicine pill which you take, if the pill is between your thumb and the index finger, and this is a sort of tremor that the patient has, that is pill rolling tremor. Patient can have jaw tremor, the patient can have foot tremor, the patient can have chin and jaw, as I said. Very rare to have a head and a voice tremor. If the patient is seen to have a head tremor or a voice tremor, you need to consider an essential tremor, which can occur in unison with the Parkinson's disease, or probably all this while what you were probably seeing as a tremor is not a Parkinson's disease tremor, it's an essential tremor. Now we come to the postural instability of the trap, tremor, rigidity, akinesia, and the last one, one of the major cardinal manifestation, and that produces a change in the patient's clinical scenario because it's poorly amenable to treatment and has a lot of disability because there is an imbalance and the loss of writing reflexes and the patient starts falling. This postural instability in a case of idiopathic Parkinson's disease comes very late in the course, let us say around 4 to 5 years after the patient has been diagnosed. And it's a red flag if the patient has a postural instability quite early in his diagnosis. How do you check for a postural instability? Asking him to stand from a chair, asking him to walk and see whether he's able to. And to have a testing done on him, we do the pull test. But then you should be very, very careful when you're doing the pull test because you know that the patient has got a postural instability, he can fall and fracture. So it is, if you imagine that this is a patient, you imagine that this is a patient, the patient is looking here, the patient is steady, the patient has got his shoulders all put up, and the medical personnel is standing here, and he pulls the patient back. Any person, you can first check on your colleagues, you pull the person back. If you take 1 or 2 steps to straighten yourself and keep yourself in balance, that is okay. But a Parkinson patient cannot, and he starts falling back, and then he can fall, and you need to take care of him. So pull test is positive for the patient. That means that you need to make a lot of changes in his day-to-day activities, because falls and fracture are one thing which Parkinson's disease patients keep coming into the emergency and have a bad prognosis as well. Now we come to the gait of the patient, that is the walking of the patient. So as we said, when the patient walks, he has got a stooped posture, he has got a reduced arm swing, he has got short and shuffling gait. And when the patient turns, when we turn, we just take one leg and then the leg turns and then we turn like this. But a Parkinson patient turns en bloc. If he is like this, he just turns the whole hands, legs, trunk, face, neck, everything turns like one block, and then he has got poor writing reflexes. Later on in the course, there are two things which happens to the patient, and they are known as freezing of gait, that is fog, and festination. Freezing of gait is when the patient has got a start hesitation or a turn hesitation. Freezing of gait, if you could look at the name of the gait abnormality, is that the legs are frozen to the floor. Either if the patient is standing and is just as Mr. XY said, please come off now. So he's just stuck there. He can't initiate. So what happens is legs are still frozen to the ground, but his upper trunk en bloc starts moving forward and he falls, because his center of gravity is still stuck there, but his upper portion has still moved out. Or it could be turn hesitation. As I said, when he is trying to move en bloc, his legs become stuck to the ground. Again, he falls. Festination is another form of gait abnormality in which I spoke about the speech, that suddenly the patient starts speeding up his speech. In the same way, the patient starts walking in short and shuffling steps, his upper trunk goes forward and he speedens up his amplitude of gait, and he starts festinating. Again, there is the repercussion to that is also a fall. So gait abnormality comes quite late. Prominent gait abnormalities like freezing of gait and festination come quite late in the. So there are certain staging. I wouldn't go into them in depth, but I would definitely want you to read about them. That is modified Hain and Ya. That is 0 is no signs. Stage 1 is unilateral. Stage 2 is bilateral, but able to walk. Stage 3 is mild to moderate. Some postural instability, physical independent, comes walking to your clinic without any support. Stage 4 is severe disability, and 5 is wheelchair bound or bedridden patient. The another one, if any of you are probably interested in research, is the Unified Parkinson's Disease Rating Scale, which has got 4 subscale, covers mentation, behavior, mood. 2 covers activities of daily living. 3 is a clinical rating scale. Subscale 4 is complications of therapy. So we have covered the bradykinesia, we have covered the rigidity, the resting tremor, the postural instability. Next, we come to the good response to levodopa and absence to atypical features. Now, what is that? What are the atypical features? When you are checking for a patient, when you're examining a patient, any neurological patient for that matter, you need to have a whole load of every neurological perspective to be checked out, because you shouldn't be missing out a mimic or an atypical patient. So what are the red flags? As I mentioned, festination and freezing of gait and the moving en bloc are quite late, around 5 to 6 years after the patient develops and has falls. But if the patient within the first year of diagnosis starts falling, then it's a red flag. It could not be an idiopathic Parkinson. Patient, you start the patient on levodopa, he doesn't have a good response. There is a symmetrical disease. That is, the patient has got bilateral rigidity. Patient has got a rapid disease progression. He started having tremors. He's from the Hain and Ya stage 1, 2. He becomes bedbound in the stage of quite early in the course. Let us say in 1.5 years. Absolutely no tremors in all across the years in his clinical scenario. Prominent autonomic manifestation, as I said, non-motor manifestations. There were psychiatric complaints, pain, autonomic manifestations, and sleep disturbances. But very prominent is what I'm saying. There is symptomatic orthostatic hypotension. The patient gets up, the patient has a syncope, the patient falls, patient has a fracture. And if you would check the postural blood pressure, so just one line about the postural blood pressure, making the patient lie down. checking the pulse rate and the patient's blood pressure, making the patient stand with the sphygmomanometer cuff on the patient's arm in the same way at 3 minutes with the BP instruments kept on the at the level of the arm, systolic blood pressure and a diastolic pressure drop off around 30 to 15. Even a 10 to 15 of a symptomatic orthostatic hypotension, if it is prominent early in the course, then it could be a red flag. And predominant and ongoing lower limb tremors, if they are there, dementia, behavioral signs, cerebellar signs, eye movement, and bulbar. That means to say all the other clinical manifestations which are away from the extrapyramidal manifestation, that is cerebellar, dementia, behavioral, eye movement, and bulbar involvement, they are red flags. So the red flags, that means there should be a complete examination which includes the cranial nerve, the cognitive examination, cerebellar signs, and a postural blood pressure in every patient of Parkinson's disease, until you cannot say that the patient has got a idiopathic or a typical Parkinson's disease. Now, what are these Parkinson's disease plus signs? I would just like to mention the names here. The predominant ones are the multiple system atrophy. If the patient has got extrapyramidal syndrome and all the manifestations with that, the patient has got classical cerebellar signs, or the patient has got very prominent autonomic manifestations like urinary disturbances, syncope features, sweating abnormalities, postural hypertension, clinically as well as documented, the patient could be having a multiple system atrophy. Patient has got progressive supranuclear palsy. Two factors, it should be like a red flag for you. Patient has got prominent falls, and that too backward falls, very prominent in the course of the disease, and vertical eye movement abnormality, that is gaze palsies, vertical. Patient able to move his eyes here and there, but patient does not move his eyes vertically. Corticobasal degeneration, in which the patient has got an alien hand, feels that the hands are it's got a parietal hand. He feels that this any of his limb is not his own, with other classical features also with the CBD. Dementia with Lewy body, in which the patient has got characteristic cognitive decline, as well as patient has got psychiatric manifestation as well. While the patient is on treatment, as we are not going to check on touch on the pharmacological, but while the patient has been kept on pharmacological, there are certain motor manifestations of the patient. One should know when the patient is on admission or when the patient comes to the outpatient, that is known as a wearing off. You have put the patient on a syndopa. The patient's syndopa works, let us say, for 4 hours. And it was continuing to work for 4 hours for a pretty long period of time, say 1 to 2 years. But then gradually over the period of time, the patient's syndopa started wearing off. That is, from 4 hours, this came off to 3 hours. It comes off to 2 hours. That is, the effect of the drug starts wearing off and the patient starts getting rigid very early, and the medications we cannot manage. That is known as an on and off phenomenon. You would keep hearing the consultants whether he's on an on or he's on an off. So on is on medications, the patient does not have prominent extrapyramidal features. Off is when the patient is on a patient has got severe extrapyramidal features. So the on and off cannot be predicted in the later forms when there is a wearing off of the medication. Then there is something that was delayed on, when the patient used to have, after he takes a syndopa tablet, half an hour to 1 hour, the patient starts getting back to his normal, but the patient starts having the delayed on. He's not able to get the desired response pretty long, in long hours, and that's known as a delayed on. Another very important manifestations while the patient is on levodopa therapy is dyskinesia, which is an involuntary erratic rhythmic movement of the face, arm, leg, and trunk. And that can be in the peak of the medication, or it can be in the intermediate, it can be in the off. That is why the patient should have a chart where he should write his on, he should write his off, and where the patient is having this abnormal movements. I thank each one of you. That is just the clinical approach to a patient with Parkinson's disease, and a Parkinson's disease and the patient and the caregiver and all the people who are with him or her. There is a movement disorder society in the country for all of you. If anybody wants to register, they can go onto this website. There are several chapters all across the country, and it is absolutely free. And during this pandemic, every sessions to the patient are being taken in the webinar way, and that is the Parkinson's Disease Movement Disorder Society of India. Thank you very much for a patient listening.
Thank you so much, ma'am. Thank you for delivering such an informative and elaborative session. It has surely added so much to our knowledge regarding the management of Parkinson's disease. Thank you. Ma'am, as we were streaming live on YouTube, there are a couple of questions that we have received via YouTube and a few questions in the chat box on Zoom. So can we take a couple of them?
Sure.
Yeah, thank you, ma'am. So the first question is, drooling in the patients can cause awkwardness in social situations. So how is it managed?
So drooling per se does not have any pharmacological treatment, but there are certain anticholinergic medications which are available, which can be given, but we should understand that they also produce a lot of side effects to the patient. So most of the time, as again I was saying, that there are certain non-pharmacological advices which are given to the patient, and that is why we encourage the patients to join the support group where they teach the speech as well as the guttural therapy, which can help them to reduce the drooling.
Thank you, ma'am. There's one more question which says, as per studies, coffee intake is associated with reduced risk of Parkinson's disease. So are there any more dietary habits which can be adopted by the patient in order to improve the PD status?
Absolutely. I feel that for any healthy neurological status which a person may want to have, the person should avoid any of the habits like smoking and drinking. Even coffee or tea should be in moderation, because there are documented evidences for anything is not there. Secondly, a good physical activity of around, you say that a moderate physical activity, at least 5 days in a week for a patient. It could be running, it could be jogging, or it could be in your own house, or yoga. All have been documented to, even if the person develops a Parkinson's disease, the speed of the Parkinson's disease and the progression of the Parkinson's disease definitely has a bearing on the pre-morbid condition of the person.
Thank you, ma'am. So the next question is, what is the supportive care which is given to a person who is suffering from Parkinson's disease?
One is the pharmacological management for the patient, and there are a lot of non-pharmacological therapies which the person needs to do in his day-to-day activities in his house itself. As I was telling you, that there is something known as the freezing of gait as well as festination. So freezing of gait, we ask the patient to have laser pointers, because some of them have got very severe freezing of gait. And if you give them some visual cues, they are able to walk onto that. If you put a pointer with a light on that, they can take that visual cue and they can step over that pointer. So in the house itself, we ask the patients to have strategic lines drawn, which are radium lines, which will be fluorescent in the night itself, so that when they are moving around, they can take those visual cues and they can step forward. The rest is the speech therapy and the occupational therapy, which are part of the society itself. They need to go to the concerned departments and learn those, and they can moderate into their day-to-day activities.
Thank you, ma'am. The next question is, can eye changes help in the diagnosis of Parkinson's disease?
Eye changes are an important clinical criteria in which a vertical gaze abnormality, which is seen prominently early in the course of a Parkinson's disease, Parkinsonian syndrome, I would say, an extrapyramidal syndrome, it would be more in favor of a progressive supranuclear palsy. Otherwise, slow saccades can be there in a patient, but then slow saccades early in the course goes in favor of a PSP. If the patient has got prominent cerebellar signs and cerebellar eye signs, then they would go more in favor of a multiple system atrophy. So one should be careful to check the eye signs. If the young individual comes to you and the patient has got extrapyramidal syndrome features of rigidity and bradykinesia, eye signs again are very important. One should always look at the KF rings. They are known the case of leisure rings, in which in a young person may look like a Parkinsonian, but you do not want to miss out a very good treatable disease like a Wilson's disease.
Thank you, ma'am. Ma'am, is it okay if we take a couple of more questions?
Yeah.
Yeah, okay. So the next question is, how do you manage a Parkinson's patient who is having epilepsy?
Parkinson's disease is a neurodegenerative disorder. Epilepsy is a disease of the brain in which there are sudden interrupted sparks in the brain. Both of the neurological disorders are different entities altogether, and both have got medications which can be treated in their own right. So there is no difficulty in treating both of them. Having said that, if both of them are in one single patient, one always needs to have an imaging done for the patient to check out whether there are any space occupying lesions for the brain, which is a frontal lobe lesion, probably which is mimicking like a Parkinsonian syndrome and is also having seizures. The patient could be having a normal pressure hydrocephalus. The patient could be having a multi-infarct dementia because of which he is looking like a Parkinsonian patient, extrapyramidal syndrome, but then he has got something which is known as a secondary Parkinson. To have two neurodegenerative disorder, one should always have a red flag and investigate the patient accordingly.
Thank you, ma'am. The next question is, as in Parkinson's disease, people are administered dopamine agonist or cholinergic antagonist, which can increase the risk for developing arrhythmias. So what is the drug of choice for the patients to treat arrhythmias in that case?
The arrhythmias in patients are very less. We haven't seen Parkinson's disease is a neurodegenerative, and as I said that the percentage of Parkinson patient increases after the age of 65. In its own right, while you're taking the patient and you are examining the patient, you would have already done a cardiac checkup for the patient to see if the patient has got any ectopics. If the patient is having any ectopics and if you're worried about that the ectopics can become prominent, then you need to switch over the patient to levodopa combination, and that could be better for a patient rather than an anticholinergic in that case.
Thank you, ma'am. The next question is, how is hypothyroidism and Parkinson's disease related? Is there any correlation between the two?
There are several correlations in which they can be, as I said, secondary Parkinson's patients can be there. What happens in hyperthyroidism also, the patients can have tremors, and sometimes the patient's tremors are also thought to be having a Parkinsonian tremor. But again, hyperthyroidism, the tremors are not rest tremors. They are not classical pill rolling tremors. They are not classical unilateral tremors. Any of the secondary tremors, which could be medication related, or it could be due to secondary hormonal or metabolic related, are usually bilateral, and they're usually symmetrical and usually postural as well.
Okay, thank you so much, ma'am.
Ma'am, just to add on to this question, ma'am, are these tremors usually treatment resistant, right?
The Parkinsonian tremors are not treatment resistant. They can be very well managed with medications. And if the medications after a period of time lose the efficacy, and as I said, there is a wearing off effect of the medication, there are other surgical modalities which are available like deep brain stimulation, which can be done in select patients, provided they do not have any psychiatric manifestations, they are not having predominant dementia, they have got a good caregiver with them who can look after them, and the UPDRS scale is taken everything in the right perspective, the patient can go for a deep brain stimulation as well.
Thank you, ma'am.
Thank you so much, ma'am. That brings us to the end of the Q&A session. I thank you once again for spending your valuable time in answering our questions.
Thank you very much. Thank you very much.
I now hand over the session to Pooja to deliver the vote of thanks. Over to you, Pooja.
Yes, thank you, Kuldeep. On behalf of the Pharm D community, I want to thank our speaker for today, Dr. BINDU MENON ma'am, for conducting such an interesting and informative session. Thank you, ma'am, for taking time out of your busy schedule to come and deliver such an engaging session. I'm sure this session will be useful for all the participants, including the clinical pharmacists, the doctors. Lastly, I also want to thank all the participants who have joined us from all over the country. Thank you for spending your time with us. Thank you, ma'am.
Dear participants, the links for the feedback form as well as the future webinar links have been posted in the chat box. And for those who are watching us on YouTube, the same is done on YouTube. So kindly do take out your time and fill these links so that you can receive your certificate at your earliest. Apart from this, only 100 certificates are delivered daily. So kindly wait for this complete week. Like you'll be receiving the certificate for sure if you have attended the live webinar. That is 90% of the live webinar, and you filled the feedback form. Both these conditions are compulsory, so you need to do this. I'll be shutting down the Zoom link by 7:35. Like I would request you all to quickly fill up the registration form, as well as like if you're interested for the future webinars, and the feedback link for the e-certificate. Otherwise, if someone has some kind of network issues, you all can always visit the Pharm D Community YouTube channel, and in the description the link for the feedback form is provided, so you can go to that and you can fill up the form. Kindly note that this link will be activated only for 5 more minutes even on YouTube. So if you're filling it up on Zoom, kindly be a bit quick and fill it up till 7:35, or else you all can switch over to YouTube and you can fill it till 7:40 over there. Thank you so much everybody for attending. Hope to see you all for the next webinar.